So, now we will go to the discussion on each indicators, taking like ventilators, CAUTIs and central line. First, coming to the ventilator associated pneumonia rate, how it is going to be calculated. Again, the formula is very simple: number of ventilator associated pneumonias cases in the hospital divided by number of ventilator days into 1000. This will give you the VAP rate of your hospital, where again you are going to write in the first column the type of ICU, number of ventilator days in the particular ICU, how many infections and what is the VAP rate, and then what is the date of culture positivity and what is the outcome. This everything has to be documented clearly and legibly, so that when we produce the data in the meeting, if anyone asks any references, we can reproduce it immediately. The raw data has to be maintained and it has to be supported. In the next slide, if you see about the VAP study pro forma, how are you going to do the VAP study pro forma? How are you going to collect the data and how are you going to analyze it? See, if the ventilator associated study pro forma, again if you see the first column about the details of the patient, second column is again about the information related to your admission and the discharge and what is the length of stay, and also it also has about the ventilator information, when the device has been connected to the patient, what is the date and when it has been removed. So, it has place of intubation, date of intubation, and if the tracheostomy has been done, what is the date of tracheostomy and whether there is any risk of MDR pathogen. How are you going to see whether the patient has the risk of multi-drug resistant pathogens? It is little bit difficult, but if you take the patient history, that will give you very clear cut idea about the patient is having the chances of harboring multi-drug resistant organisms or not. Like suppose if I give you an example now, the patient comes to the emergency room ER, and if you are going to intubate and you want to know whether the patient is a risk for MDR pathogen. So, some of the factors which can cause and which can make the patient to have MDR pathogens is that history of transferring the patient from one healthcare facility to another healthcare facility, or history of any antibiotic use in the last 30 days, or history of any procedures have been done, invasive procedures on the patient in the last 30 days, or the history of patient being exposed to the healthcare setting in the last 30 days. So, if you take an history, that will give you a very clear cut idea whether the patient got exposed to the healthcare environment, patient got exposed to the multiple antibiotics, patient got exposed to any major or minor invasive procedures. All these things will be a risk factor for the patient to develop the MDR pathogens. So, the history plays a very important role, clinical history plays a very important role. So, it is a role of an infection control officer, the responsibility of an infection control officer and the infection control nurse to go through the patient case file in detail whenever they are documenting any information related to the patient's condition. Coming to the next slide now. The continuation of again the VAP study pro forma. If you see here again, you have all the details about the antibiotic history as I discussed just now, and also about the second line antibiotics and how it has been diagnosed. CDC and National Health Safety Network has given very clear definitions about the hospital acquired infections. So, if you see here the VAP diagnosis, how are you going to do, whether it is a pneumonia 1 or a pneumonia 2, this detail we will be going through when we discuss about the infection control indicators in detail. Now, going to the next slide after the VAP ventilator associated pneumonia pro forma, if you see the ventilator bundle checklist, this is very important. The theme of the module is the prevention of hospital acquired infections, and this prevention can only be done with a proper surveillance, proper education in the hospital to the infection control nurses and the stakeholders, and also bringing the awareness about the infection control policies and making sure their implementations at the respective places is very important. Each and everything plays a major role in the education, bringing the awareness, forming the policies, implementing the procedures, monitoring the outcome and analyzing it and presenting in the committee. That is what the role of the infection control department is. Coming to the ventilator bundle checklist, again if you see the checklist in detail, it has the patient details on the top. All the patients have to be traced by a unique ID number, whether it is an outpatient or an inpatient, all the patients should have a unique ID number. And if you see in the ventilator bundle checklist pro forma here, the important points is daily hand washing has to be done. First thing, as I told, hand washing, oral care, some of the units they give oral care with the chlorhexidine mouthwash or betadine oral gargle, and also make sure the patient head end of the bed should be elevated at 30 to 45 degrees. Patient turning and rotation is very important. Again, patient may again end up in having bed sores if you do not turn the patient frequently, because most of the patients on ventilator are sedated, or they are in coma, or they are in having some metabolic problems where they are not fully conscious. So, they have to be turned frequently, and also daily assessment of readiness for weaning the ventilator mode. This is very important. It has to be done religiously. It has to be done on a regular basis, at least 2 times in a day. Go and see the patient, find out whether the patient can be extubated. If it is there, then slowly try to wean off from the ventilator, go from the pressure volume control slowly to SIMV pressure support, and slowly try to wean off the patient and see the patient response to the breathing and all that things. Do the daily assessment and also give the DVT prophylaxis, because most of them are bedridden and they are not doing the leg movement, the chances of thrombosis in the vessels. Do the regular closed suctioning. Again, some of the studies have shown the difference between the open and closed suctioning. Closed suctioning has an advantage of having less risk of infections, and also make sure the stress prophylaxis have been given to the patient. So, these are the ventilator bundle checklist. We are going to do it regularly. Make sure it should be a checklist, it should not be a tick list, where at the end of the day the nursing staff is sitting on the corner of the room and ticking all the columns. If we do it again like that, then there will be no purpose of keeping the checklist in the ICUs or in the high risk areas. It has to be done regularly, it has to be done the moment you finish the work, then only the outcome of this type of implementations in the hospital turn out to be fruitful. Now, coming to the next indicator, first we will discuss about the ventilator cleaning checklist also. It is also a very important part, where how are you going to clean your ventilators, how are you going to change your filters which are there in the ventilators, and how are you going to do the environmental cleaning. That is very important part. Again, this is a small checklist where you do the cleaning, you see the cleaning parameters, as I said just now, cleaning of the outside of the ventilators, cleaning of the membranes and the filters of the ventilators, and their maintenance once the patient get discharged. Before being used for the next patient, the checklist for cleaning has to be seen meticulously, both by the nursing staff and the biomedical department, to come and see that the filters are working or not, and the filters have been changed or not. This is the next indicator which we are going to discuss about the urinary catheter associated UTI. Catheter associated UTI is the first most common cause of infections, hospital acquired infections in the hospital, followed by ventilator associated pneumonias, then followed by surgical site infection and central line infections. Though some of the hospitals may have some parameters differences there, some may experience that more common ventilator associated pneumonias followed by CAUTI. Now, we will discuss about the catheter associated urinary tract infection. How are we going to calculate the rate? It is again the same formula, the number of catheter associated UTIs, suspected hospital acquired. We are discussing only about the hospital acquired infections, not the community acquired infections. Only those infections which the patient get after 48 hours of admission into the hospital, which was neither there at the time of admission, nor the patient was incubating the particular organism at the time of admission. So, again number of hospital acquired CAUTIs divided by total number of catheter days, as we discussed just now about the ventilator days, into 1000. If you see again the above the table, it is same like where the ICUs, number of catheter days, number of infections, and your CAUTI rate, how many of them turns out to be culture positive, and what is the outcome, whether ultimately patient got discharged or patient had some complication and mortality. So, next slide, if you see here now, the catheter associated study pro forma. Like how we have just seen the VAP associated pneumonia study pro forma, we also need to maintain a similar study pro forma for catheter associated urinary tract infections. Now, we will see what all the details are there in this pro forma. If you see again here, this is again type of surveillance form with the patient details, and when the patient admission details, and when the Foley's catheter has been kept, and when it has been inserted and removed. And again, if you see in the lower side, the risk factors as we discussed for the ventilator associated pneumonias, same applied for the catheter associated urinary tract infections as well, where we have again the risk factors for MDR pathogens and what type of organisms we are suspecting, whether it is an Acinetobacter baumannii or it is a Pseudomonas aeruginosa or E. coli or Klebsiella, and what is the antibiotic history, again as we discussed what antibiotics the patient has been exposed into the past, in the past and what antibiotics is on right now. The next slide, the continuation of the catheter associated study pro forma. If you see here, again the antibiotic history and the UTI event information and details. If you see here, the diagnosis as per the CDC guidelines, as I discussed just now, the colony count of 1 lakh CFU per ml, and it is a pathogen, we can take directly. And if the colony count is between 10 to the power of 3 to 5, again we are going to see the pus cells, CUE pus cells in the urine, and also we are going to do the gram stains. So, similarly, again it goes like that. Again it who is the data collected by the name of the infection control nurse, and the data has been scrutinized by infection control officer, his name. Coming to the next slide now, about the CAUTI bundle checklist, which is again an important theme of our module. Like how we have seen the ventilator associated pneumonia bundle checklist, like daily seeing the patient, hand washing, and seeing the head end of the bed is elevated or not, daily assessing the patient whether it can be removed from the ventilator or it can be tapering can be done for the ventilator settings. All these things plays an important role. Similarly, we have a CAUTI bundle checklist, where in this slide if you see, we are going to see the catheter associated urinary tract infection checklist. If you see here, the daily, again it is a bit documented with the what is the date, and there is a daily documented assessment, again like how we assess the ventilators intubations. Say again we will be assessing the catheters, and urine catheter has been continuously connected or not, whether it has been disconnected. Again if it is disconnected, the more you disconnect, the more chances of infections. Metal hygiene has been performed or not, it is very important again. And for the circumcised and uncircumcised patients, where there are again chances where the organism can get deposit and cause infections. And empty the urine catheter bag often as a separate procedure into a clean container. Make sure that bag should be emptied on a regular basis, and hand hygiene should be performed. Some of the important points again what we are going to discuss here is, never take the urinary catheter bag above the patient level, because again there is chance of urine present in the bag goes into the tube, and again it can cause infections into the bladder if it again regurgitate and it goes back into the bladder. So, this is to be avoided. Make sure the catheter bag is below the patient level, and see that the catheter is not kinked, it is not been crossed, or it has not been moved from the place where there are chances of obstruction of the urine can be there. And again the stasis of the stasis of the urine in the bladder, more the chances of infections. See the patency of the urobag, see the patency of the urotube, whether it is patent or not. So, this is the checklist which we are going to follow for catheter associated urinary tract infections.